here now on excellent third year medical student who kind of put a lot of work to push this project forward, and my partner in neurosurgery, Nader Dadaway, who should be on as well.
Excellent. Well, yeah, guys, well, welcome. We'll get started. It's 4:02. Welcome to Tumor Talk. This is a collaborative effort between the neurosurgery department at Lenox Hill and the Journal of Neuro-Oncology. We started it, way back in March or so, where we bring in authors of recent publications and we talk about really the reasoning, the results, and the relevance of papers they've recently published. And so we're pleased to have, you with us, Sean, and your colleagues. I'll let you again just introduce everyone, and
Sure.
The typical format is an informal discussion, a couple minutes. You guys can show some slides if you want to talk about the paper, and then we'll just talk openly and candidly about everything. And we can take questions from the audience as well. So sometimes we'll get some chat features going on. All right.
Perfect.
Take it away.
Thank you, Randy, for the opportunity. Also on behalf of my co-authors to present these data and what we're hoping to do exactly as you described with Rowan, our excellent medical student, just to give a taste of what we presented in our paper, and then that could be a nice segue to a discussion afterwards. And of course, we also have my partner in neurosurgery on, Nader Dadaway, who's an associate professor and a spine tumor expert. Rowan, if you wanted to share your slides, you can get going.
Yeah, Rowan, you're on mute too. I don't know if you know that or not.
Yeah,
I'll hold up my mug when you're on mute.
I love that. Thank you. All right, let me get my screen shared here real quick. All right, can everyone see this?
Yeah, we're good.
Okay. I'm just gonna move some things around. Okay, thanks for joining everybody. So we're presenting here our paper entitled Long-Term Outcomes of Spinal Ependymomas, Our Institutional Experience of More than 60 Cases. So just a brief introduction on the topic. So these are very rare tumors, spinal ependymomas, but they do represent about up to 45% of primary intramedullary spinal cord tumors. And it's primarily a surgical disease. Gross total resection, or GTR, has been shown to be a pretty significant factor with improved progression-free survival as well as overall survival. But then adjuvant therapies like radiation therapy is recommended for more high-grade ependymomas like grade 3, as well as grade 2 ependymomas that have been treated with a partial resection or subtotal resection. Grade 1 disease is traditionally treated surgically. So the retrospective review that we did, we wanted to add to the very limited data, just given the prevalence of these tumors, and add to any impacts that we can do on long-term survival and recurrence. So the methods for our study, so we have an enterprise data warehouse here, and we found 69 patients with histopathologic evidence of the primary spinal ependymomas. We excluded 4 of these patients because they did have radiographic leptomeningeal dissemination and presentation, but we are in the process of making a separate series for review on those cases and their management. The primary outcome that we are dealing with here is progression-free survival from the time from radiation therapy or surgery to recurrence, progression of the disease, or patient death. And these were determined by radiographic evidence compared to a previous scan done on the patient. You can see the table 1 here, characteristics of our patients. So we had a pretty even distribution, specifically looking at the grade of the tumors here. We had 20 grade 1s, 42 grade 2, and only 3 patients with a grade 3. Tumor site, again, pretty even distribution, primarily in the cervical and lumbar regions. Also pretty even split on gross total resection, 35 versus 30. And then radiation therapy, slightly more, no radiation, 40 patients versus 25 who did have radiation. In terms of our analysis, so we used Kaplan-Meier estimates to summarize our overall survival and progression-free survival, as well as local control rates using 95% confidence intervals. In order to determine factors that would predict a patient's likelihood of receiving adjuvant radiation, we used a multivariate logistic model. And these are some of the variables we used: age, degree of resection, GTR versus STR, the grade of the tumor, date of diagnosis, as well as the location of the tumor. And then we used log rank analysis to assess the differences between our patient groups. A brief overview of patient and treatment characteristics, like I described earlier. So we had 25 patients who did receive post-surgical adjuvant radiation, about 38% of our patients. 2 of those patients had received GTR, but the vast majority was post a subtotal resection. From our records, the median RT dose or radiation dose was 54 gray with a range of 45 to 66.6. And the median dose for lesions above the lumbosacral spine was 52.2 gray with a range of 45.1 to 60. In terms of follow-up, the median follow-up that we had for our patients was 5.7 years, and time to recurrence was 4.3 years. 7 of these patients did exhibit distant disease progression outside of the local tumor, and 6 patients exhibited local disease progression. So outcomes by treatment group. So grade 1 ependymomas, remember these are traditionally the surgically treated group of patients. 10 of these patients had a subtotal resection with 5 and 10 year progression-free rates of 68.2 and 45.5% respectively. The median overall survival of 9.3 years. The gross totally resected patients had 100% survival to 10 years without any events during the follow-up period. Shifting to grade 2 patients, we had 42 of them. Patients who received a gross total resection without adjuvant radiation, they had 5 and 10 year progression-free survival rates of 190% respectively. 2 patients received radiation therapy status post gross total resection, and they had no disease progression at 3.4 years and then 4.1 after follow-up. Our subtotal resected patients who did not receive radiation, their progression-free survival rate was a bit lower at 5 and 10 years of 68.2% and a local control rate of 50%. And then finally, our subtotally resected patients who did receive adjuvant RT had 5 and 10 year post-survival progression-free survival rates of 77% with local control about 86%. And these are just some graphics here to demonstrate some of this overall survival. You can see overall survival for all of our patients seemed to range around close to 100% at 10 years. And then shifting to some of our events around 14 to 15 years. Progression-free survival here, you can see this as well for all of our patients. And then our final graphic here, specifically focusing on our 4 different treatment regimens for our grade 2 patients, GTR with and without radiation, and then STR with and without radiation. I'll just briefly touch on this. I might hand it over to Dr. Sachdev too, but this is just an image that we have of our a sample of our IMRT dosing. In terms of outcomes by treatment group, this is that one of the points of data that I mentioned, that we looked at the predictors of receipt of radiation therapy, broken up by these different variables, doing a log rank analysis here. Just want to draw your attention to when it came to significant variables, degree of resection was the key significant variable that we found with an odds ratio of 0.038 and p-value of less than 0.0001. The rest of these values here are above our 0.05 cutoff. So main discussions and items for conclusion. Based on our study, it seems that it's very reasonable to monitor a slow-growing lesion or primary tumor that's undergone significant or near total resection, especially in younger patients who may carry some more risks with radiation therapy, and it may be advisable to defer that for later. In addition, radiation therapy can also prevent spinal tumor dissemination as well as progression of any residual disease, but it could also subsequently cause neurological deficits or death. Post-surgical adjuvant RT is definitely likely to improve outcomes in patients with subtotal resection of grade 1, as we saw half of our grade 1 patients had subtotally resected tumors, or in instances when total resection is simply not feasible. Local control rates in PFS were definitely improved in patients with grade 2 ependymomas with STR with radiation therapy versus without radiation, and the survival benefit extended to the 10-year mark. Overall, very considerable conclusion that GTR definitely conferred the best progression-free and overall survival across all treatment groups. And then that subtotal resection was the only statistically significant predictor for a patient's likelihood to receive post-surgical radiation therapy with a pretty significant p-value. Just a couple limitations to our single institution study. It is a single institution by nature, so this retrospective design does have its implications, as well as the fact that there's possible evolution in grade attribution during the inclusion time period. There's definitely maybe histological changes in how grade 2 versus grade 3 tumor can be characterized from a time a patient was diagnosed back in 1990 versus now. And those are our slides.
Thanks so much, Rohan.
Thank you.
Mm-hmm.
Yeah, great work, especially as coming from a medical student. I read this paper with great interest. The timing was perfect because I was just dealing with a young woman who I was taking for resection for this, and so I was curious what this is a large series in terms of ependymomas, and it's one of the few out there, and so it offered me a lot of insight. One thing that I found particularly honest, and I thank you guys for, is the extent of gross total resection published, right? This is, you're given one chance with these patients, your upfront interaction with them, and every time you encounter them that the best possible thing for them is a gross total resection. But the truth is that it's not really that possible. Not every case, right? You guys are showing 50% for both the myxopaps and the cervical, grade 2s. And I think that's honest and that's true, in which case you have to start thinking about how you're going to treat that other half of patients that you can't get the gross total in. I don't know if you wanted to just comment on that briefly.
Sure.
Yeah, I agree. I mean, just for me, I really didn't know anything about this disease when I first started doing this research. And when I was just reading some of the articles, it seemed like I kind of understood the idea that well-encapsulated tumors are more easily surgically resectable. And I found that kind of coincided with the nature of myxopapillary and subependymomas. But I guess when you actually look at the data out there, it's a lot more complicated than that. And sometimes that resectability doesn't always translate in a real patient. So that was definitely something that I learned coming out of this.
I'll just make one point. As Rohan described in the method slide, when we looked at outcomes for patients that got radiation, it was actually from the end of radiation. So it wasn't really, you truly want to test whether or not a modality is going to be beneficial for a patient's outcome before you start likely, recommending it. And so in cases of a subtotal resection, our data, as shown, are in line with what has been reported previously. There have been some good papers in the JNO, previously published, including a series from WashU and a few other papers that are largely, in line with what we reported. And so I think, and I'm happy to have Nader speak on this as well. With good surgeons like Nader, when you can get it all out, that's great. But if not, if it's just not, if it's a myxopap that we just can't get out fully, then for the appropriate case, adding on radiation would really improve long-term outcomes.
Absolutely, thanks. No, I agree with you, Sean and Randy and Rohan. I mean, upfront with the patient, you tell them if for intramedullary tumors, sometimes you have a suspicion on the pre-op imaging, and you tell them, we're going to go in and get a frozen section. If it's an ependymoma, then we want to aim at a gross total resection, given that we're not doing any harm. Like, there are no signal changes during the operation, like while we're resecting it. The borders between the tumor and the normal tissue are easily identifiable. No, for myxopaps, it's easy. You can figure that out pre-op and tell them, we're going to aim at the gross total resection. But in either cases, you aim at that, but sometimes you don't achieve it. Don't want to do no harm, given that we have other options post-op that we can offer these patients with radiation therapy. Now, with a residual tumor, whether it's a myxopap, grade 1 or a grade 2, we always refer our patients to Sean to make that discussion, whether, radiation therapy versus continued follow-up, maybe the threshold to watch them for a grade 1 is lower than for a grade 2 with a residual tumor. The grade 1, you'd say, well, there's a little bit there. Sometimes, you want to resect the phylum too, with the mixopap, so it doesn't come back. And if there's some enhancement, we're not sure if it's tumor or not tumor. We watch that, but definitely it's a as in tumor oncology, it's a multidisciplinary approach where we engage, Sean, patient, ourselves, and sometimes, rarely a neuro-oncologist, but usually radiation oncologist in those discussions. But this study is fantastic because it shows that radiation therapy offers the patient a better advantage in terms of progression-free survival in cases of having a residual tumor, no matter what the grade is, no matter where the location is.
Yeah, I agree. I think it's reassuring as well. So let me ask you this, because based on the data you guys showed, it looks like none of the myxopapillaries in your group, and that was pretty much all the grade 1s you guys demonstrated, underwent subsequent radiation. But it also looked like in the conclusion slide you were saying that you would consider this. Now, based on the numbers you guys showed, the myxopaps actually appear a little bit more dangerous in terms of progression than the grade 2 ependymomas. I'm just curious what you guys think about that, and have you changed what you do? Would you offer upfront radiation now, or is it really a case-by-case basis?
I think it's still largely, case-by-case basis. Because this is such a rare, lesion, and in terms of general incidence, when you think of sort of, primary neoplasms in the neuroaxis, we are, encompassing a long span of time in terms of pathologic diagnosis of one of these lesions at our institution. So a lot has changed over time. A lot of the myxopapillary ependymomas largely potentially, who knows, maybe based on provider preference or based on how a patient may or may not have been doing. A lot of these patients, in cases of a subtotal resection, did not get adjuvant radiation. I've seen a couple of patients that were not included in the series. We had a few patients who were younger, who I actually referred to my colleagues at a Proton Center to try to make sure that, that we get the equally good local control outcomes in terms of lesional control, but, prevent long-term sequelae of radiation for someone who's, let's say, 19 years old. But just based on how those lesions did, how the myxopaps did without radiation, yes, you're absolutely right. We don't have the data to justify that conclusion, but it may be reasonable to consider it.
Yeah, absolutely. And what are you doing now for, a subtotal, let's say a cervical spine subtotal grade 2 ependymoma, neurologically intact young people? Are you doing upfront, or are you actually, I guess my question is let me reframe.
Sure.
One thing you don't talk about is reoperation. This is obviously people are diagnosed young. Are you guys of mind that, reoperation may be indicated since these benefits are after radiation? So you could debulk again internally and then radiate, or would you go straight to radiation immediately after diagnosis at this point?
I'll defer to Nader on that. I think it's always a nuanced discussion.
Yeah. So, it depends on the grade. I mean, it's, if you have a residual grade 1, for instance, that we think it has progressed, I think you would want to re-resect those. You want to re-resect those. Intramedullary tumors, the threshold is much higher to reoperate after a period of time where it looks okay, and then you see some recurrence. Then the threshold is higher for those to operate than to have them undergo radiation. It's rare. I'm trying to kind of think of so the series included many surgeons. I'm one of them, and everyone has his own kind of experience. So to me, like, it's a myxopap. Most of the time we're able to resect them. We resect the phylum terminale with it, and gross total resection. You'd aim at an unblock. Sometimes it's not possible if it's really big, but you want to aim at an unblock resection with the phylum so that they won't recur. If that's the case, they don't recur. If that's not the case, you debulk them. You aim at gross total resection. If they progress down the line, then you would probably you can look at a re-resection. But
Yeah.
intramedullary tumors, it's just very difficult to go back and redo it. So you probably, what's your experience, Randy?
Well, to be honest with you, I've had all of these cases recently. There's been a real uptick in spine surgery for some reason, the spinal tumors. And so I've got one patient with a myxopapillary that was a subtotal, was a very, very large tumor. And there's definitively tumor left. I was getting stim all over his sphincter, all over the place. And I stopped because, like you said, and this is the most important thing, and this is what your outcomes are supporting. We do a pretty good job with radiation of taking care of these patients for a very long time. And so rather than take a 29-year-old and make him incontinent, I'm going to let this slow tumor do its work for a little bit before we make a decision. Right. And let that kind of, harm the person, not me. Right. And so, my decision with him is basically, I'm just watching because it's a grade 1 tumor, slow progression. If need be, if there's bulky disease, we'll go back in and re-debulk and then radiate without a doubt. And then I've got another patient with a cervical grade 2, who again, subtotal, we actually lost, we lost motors in the case. We're afraid she was going to wake up quadriplegic. When D waves stayed the same, but there's still this specter of fear when the D waves are the same and the motors are gone, where you don't, I still don't trust it, even though I know I trust it,
Yeah, it's not a good feeling.
No, yeah, exactly. And so, we woke her up. Thankfully, she's fine. She's got some pinky numbness, but you get worried. And so with her, I know there's residual disease. She's young. The decision to go to radiation or wait is there. And right now we're going to wait and I think your guys' paper helped me understand that. And it's because the progression from radiation is what's controlled there, And so, if we can keep her without a deficit, keep her closely monitored and radiate when it shows its ugly face again, then I think we're in a good place. But I don't know. I think there's a lot of ways to skin a cat here. And so,
No, I think that actually, not from a surgical perspective, but from a radiation oncologist perspective, I think what you described, Randy, is actually the perfect approach. I mean, if you have a lesion that's been well debulked, maybe this is an indolent lesion, even within, certain histologic grades, there's a spectrum of, how aggressive a lesion is. There's no downside to watching it. If it's an indolent lesion and the patient does fine, then things are good. But and this is what we're hoping to show, that in cases when there is residual disease, radiation can improve long-term local control and PFS. And so that's a good option to have in your back pocket. That's something that can be discussed when needed.
Absolutely. One thing, and this is actually a perfect segue into it. You guys talk a little bit about it in your discussion, but the negative effects of radiation, right? What do people have to be worried about? We have a mixed audience. It's students, it's other, physicians, and it's patients. And so, what do you tell people, I guess it's hard to break down, but let's say cervical, thoracic, lumbar, in terms of what are the side effects, what are the risks? What's your discussion like with the patient?
Yeah, sure. From a high level view, we think, and this is based off of decades of imperfect data, we think every organ in the body has a certain threshold in terms of absorbed dose that you don't want to exceed. While microsurgery is pretty advanced nowadays, radiation therapy has, completely transformed itself over the past, I'll say, 2 decades. And now with advanced image-guided techniques such as IMRT or VMAT, like the example that we showed, you essentially have the capability to take a 3D paintbrush and paint dose wherever you'd like. So in terms of, the dose going where it needs to go very focally, staying off other areas as best as possible, we can achieve that very, very well nowadays. So as we briefly described in one slide, the higher up the cord you go, if you're dealing with sacral nerve roots, if you're in the lumbosacral spine, if you're in the cauda, you have a little bit more tolerance in terms of what that region can take. As you get to the cervical, cord or the T-spine, then you have to be really careful, how much and where you can give dose very focally beyond the safety threshold of about 50 gray. So you can, either way, we can deliver the dose very focally. You always want to be really careful when and how you give a dose, that's not to be higher than what's safe for the cord. Beyond that, now for the younger patients, we have, a new option that we didn't, easily have at a lot of different, hospitals throughout the country. Now more and more places are at least around a proton therapy center. So what is proton therapy? Proton therapy is delivering exactly the same dose to the target. So it's not so much that that treatment would work better. We'd expect essentially based in terms of the dose deposition and the physics of where the dose is going, we're giving it basically essentially exactly the same dose using either modality. The difference, however, with proton therapy is that the dose spill off, the really low dose that even a patient can't feel, that's not going to cause any toxicity, essentially goes away. And that's really, really important for your 19-year-olds and for your young patients who, as the data show, patients are not going to die from this disease as long as they're, as long as the lesion stays in control and check largely. So you really worry about, let's say a young adult who's had extensive lymphocytic mix-up papillary ependymoma who gets the adjuvant radiation. How will they do 3 decades down the road in terms of having a secondary malignancy or some late sequelae of radiation? And that's where particle therapy with something like proton therapy can be very useful.
Yeah, definitely. Well, guys, I can't thank you enough. I think that your paper was a perfect example of how a retrospective analysis of a rare disease can really offer a lot of insight. And I think it's a really great paper, and I've referred to it now at least probably 10 times in the past month, just how busy it's been with these kind of tumors. So I appreciate that, and I'll speak for Jason. I know he's not here today, but thank you for publishing in the Journal of Neuro-Oncology. I think it's a great addition and a great great time to have you guys on board. So thanks so much for coming. This will be on YouTube for people who missed it. And we'll send you guys a link. You guys can share with your colleagues and friends and family and med students and whoever you want. And we'll see you next time you publish with us.
Sounds great. Thank you for the opportunity.
Thanks, Randy.
Thanks, guys.
Thank you so
Take care,
much.
guys. Bye-bye.